if you're talking French with somebody who's also French and you're having a conversation in French, it's much easier to have a conversation French to French than having a conversation in another language. So if I was French and speaking Spanish, I'd be able to do it. I'd have to think in a different way of doing it.
Welcome to Protect, Suicide Prevention Training Podcast for healthcare professionals. I'm Manan, consultant psychiatrist, founder, and head of faculty at Progress Guide. Good day to our listeners. Today we have an invited guest attending our podcast, Shazzy Tharby. Shazzy was born in the UK and lived and worked in various countries before settling in Australia. Shazzy is biracial and multilingual. She has volunteered in the disability sector since 1996. Shazzy studied at Cambridge University and is now a registered nurse and a credentialed mental health nurse. She currently works as a clinical nurse consultant and counseling psychotherapist in her own private practice and is undertaking her master's in counseling and psychotherapy. Shazzy has lived experience in many aspects of disability, including invisible disabilities like chronic fatigue syndrome and mental health. Shazzy is a wheelchair user, proudly autistic, and lives with various autoimmune and neurological conditions. Shazzy is part of a proudly neurodiverse family, being married to Alex with two beautiful neurodiverse children. She's an active advocate for mental health and neurodivergent rights and is an LGBTQIA2S plus ally. Shazzy is focused on centering marginal and silenced voices through an intersectionality lens. Shazzy is an award-winning mentor and a motivational speaker and trainer, delivering inspiration and leadership to businesses and conferences across the globe. My contact with Shazzy was actually through LinkedIn, through some of the inspirational posts that she put in there. And it made me stop and think about neurodiversity. It made me stop and think about some of the questions I often encounter in our suicide prevention training programs relating to how to support people who are living with autism. And I could not find anyone better than to think of Shazzy, someone who is an expert living here in Australia in Perth. So welcome, Shazzy. Thank you for taking the time to join the Protect Suicide Prevention Training Podcast.
Thank you for having me.
Tell our listeners a few more interesting things about yourself, because I've seen on LinkedIn you speak very candidly on LinkedIn, and I'm often kind of quite inspired by the way you write and the things you say. So share a couple more things about yourself with our audience.
I recently learned to be my authentic self. So I've lived a long life of 25 years in the profession where I hid myself for the longest time. And so I had a bit of a, I'd walk around the hospitals in London and think, oh my gosh, why am I here? How did I get here kind of thing? That imposter kind of syndrome. But I learned so much from being on that side of things. I went into mental health, mostly due to my own mental health issues when I was at university. Mm-hmm. I kind of slid into mental health in that respect, but it was the best thing that happened to me. And I learned from the inside out and the outside in about mental health. And I enjoy working within mental health, and I've enjoyed working and finding a lot more about neurodiversity. When I first started, neurodiversity was kind of a newish thing. It'd been around since the 80s, but when I was working in the 90s, it was mostly about medicating and parent training. And then we moved on. I remember the Priory were doing some educational days on ADHD, and they picked up that ADHD was more about brain chemicals and brain reactions. And this was amazing stuff that was to come out. And we've moved on a lot since then. And that was 20 years on, we now know a lot more about neurodiversity, and neurodiversity movement is coming a lot further as well. So I think being openly neurodivergent nurse, people would want to see me more, and I have a better rapport with patients and clients than I would, I think, than a neurotypical counsellor or nurse would. People seek me out from all over the world for counselling psychotherapy. So, I have a lot of clients on my list and repeat clients too. So I think that kind of shows that it's kind of comfortable talking to another neurodivergent than it is talking to sorry, Manan. It's kind of like if you're talking French with somebody who's also French, and you're having a conversation in French, it's much easier to have a conversation French to French than having a conversation in another language. So if I was French and speaking Spanish, it would be I'd be able to do it, but have to think in a different way of doing it. Does that make sense?
Yeah. That's actually a wonderful metaphor to kind of get across how it must feel for someone who is neurodivergent to connect with a counselor who's neurotypical. Can you elaborate on that a little bit more in terms of, because I'm sure you have got counselors, friends or colleagues who are neurotypical.
Yes.
How would you be different from them? Like in terms of your ability to metaphorical ability to speak, say, French, and if they are always speaking English or Spanish or a different language, in kind of perhaps in more concrete ways, how might they be different, a neurotypical counselor compared to a neurodivergent counselor?
It's all about learning the language. So we learn the language of psychiatry through our school days, through our medical school. Learning the language of neurodiversity is another step forward as well. So we have a lot of neurodiversity affirming therapists who aren't neurodivergent themselves, who have learned the language, and they are able to communicate or at least reach out to other groups and find out how to communicate better with their clients.
Yeah. So one of the things that comes up very frequently in our suicide prevention courses is some of the challenges of working with people who are neurodiverse because of this difficulty in communicating and connecting. Because in Protect, we spend a lot of time on empathic connection. And actually, if you're, as you say, speaking two different languages, that connection might be quite difficult. Have you got particular suggestions or things that therapists, counselors, psychiatrists may try in order to form that empathic connection?
Yeah, we assume that autistics, example, don't have empathy. And there's this general assumption that autistics don't have any empathy. Well, we do. We just show it in a different way. You can get that empathetic, build that empathy with your clients. It just looks a bit different than it would with an NT and an ND.
Yeah.
So it's about looking for those differences rather than trying to see a pattern that you see in your whole life with neurotypicals. It's about, maybe checking verbally that that's been understood or that empathy is there. You might not actually see it on somebody's face or hear it in their voice, but it might actually be there.
Yeah. When we are training our professionals in mental health in Protect, we kind of talk about this concept called empathy in action. And we divide it up into three parts. The first is cognitive empathy, which is like your thoughts in my mind. So I have got an understanding of how you are thinking. The second bit is emotional empathy, your pain in my heart. I have an emerging sense of how you're feeling, why you're feeling this psychological pain or this emotional suffering that you're going through. And the third thing we talk about is empathic concern. So that is my genuine desire to help, my genuine desire to do right by you, right? And when we combine these three things together, we get what we call empathy in action, where actually you are able to convey to a person who is currently feeling quite hopeless that I am here to help you get through this really difficult period in your life, that you're going through. So that's where a lot of trainees, professionals who are going through the Protect training kind of ask that, okay, sometimes we find that particularly those who have had some exposure to working with people with autism, they would say, perhaps the cognitive empathy, the bit around the thoughts, we can work out and we can be more explicit, but the emotional empathy and being able to convey that actually I am there to help you, that is the bit they kind of often struggle with. I know this is quite a nuanced topic and often it's quite difficult to talk about in a concrete way.
Not at all. I completely understand that one. So with it might look very different. For example, you just saying that with autism, that would put most autistics back up. So you check with them what their preferred language is. My preferred language is identity first. So I am an autistic person rather than a person with autism. Okay. So straight away, you've lost the empathy with that person. You've lost them. So you checking out language usage. Your thoughts in my mind might be quite difficult because our way of thinking is slightly different than the neurotypical way of thinking. We also, a lot of us have alexithymia, so we're unable to put our thoughts into words as much, but we feel just the same. So you might have, like, I don't know if you've seen the Gottman's feeling wheel. So you might have a Gottman feeling wheel and use that with your autistic client rather than just ask them how are they feeling out the air. Asking me how I feel, like how I'm feeling, I would just be like, I have no idea. But if you show me a Gottman feeling wheel, I'd be able to tell exactly how I feel. And the empathetic concern that you talked about at the end, feeling that the empathy, we feel that automatically. So I can see it in your face, in your demeanor, in your body language, in your posture. Before you even start talking, I've seen all that already. So if you look slightly anxious, if you look like you don't know what you're talking about, I can sense all those kind of things before you even start talking. So body language, as you probably know, body language is it 74% of our communication, non-verbal communication. So that's really important is people's body language. Rather than what they say, it's how they say it, the tone they use, and what they look like when they're saying it. Those things are more important to the neurodivergent community than is thought.
Yeah.
Possibly the whole community, really.
Yeah. Like I kind of thank you for pointing that out around a person living with autism rather than someone who is autistic. I think that's a very important differentiation. And in a lot of our kind of mental health work, we now kind of things that we would say before, like say something like that now. So someone is schizophrenic. We will never say that now. Someone is with schizophrenia. And I guess the same rules apply. And in the UK, there was this survey where people were asked about if you are living with mental health challenges, what would you like to be called? Because there were lots of terms banded out, like service user, user of services, patient.
Yes, I remember.
Yeah, I don't know if you remember the survey. There was this big survey, and actually most people living with mental health challenges came out and said, I'd just like to be called a patient, just like anyone else who has physical health challenges. And but that's a really important point, that how we could, right in the very opening, we could make someone quite defensive by saying something that's in our blind spot, that we aren't even aware that might make someone recoil.
Yes. This is when neurodiversity training comes in. There's a lot of neurodiversity training out there now. Like there used to be with LGBTQ community. The neurodiverse community have their own training by neurodivergent people, which is a better way to train, which is a better way to learn from somebody who with the lived experience. As you probably know, we've learned that from mental health as well. I'm
actually quite curious to understand what are the kind of things that are covered in neurodiversity training.
Yeah, so neurodiversity training, we talk a lot about things about the neurodiversity, the way of being, the neurodiversity movement. There's a whole movement out there you're aware of, how we see the medical model versus the social model of disability. There's very much a lot to it. The language we use, a lot of people use the identity first language rather than the person first language, which is used in disability quite a lot. Some people still use the person first language. So, you really have to check out with the individuals which kind of language they like to use, but the majority go with identity first. There's been a lot of talk about ABA and using ABA techniques with neurodivergent. So essentially changing who they are, using conversion therapy to change who they are as a person.
So could you tell for our listeners who don't know what is ABA? So what does ABA stand for?
ABA is applied behavior analysis. It's dodgy ground to talk about, so I won't cover it too much, but it's basically changing a neurodivergent's way of being so they become more neurotypical. So like the old conversion therapy that was used with LGBTQ community, changing them from being who they are to who they're not. So there's a lot of controversy around that area.
Right. Okay. So some of the things that we actually don't teach in mainstream psychiatry or mental health nursing or psychology. So there's a fair bit over there. And just listening to you speak about these things, they seem absolutely fundamental in supporting someone, particularly if they are in suicidal crisis.
Absolutely vital and missed completely, especially in ED units and places like that where a neurodivergent may present and quite honestly come up and say, I'm suicidal. And they'd be like, take a seat. and the seat would be in a very brightly lit area with a lot of noise around, and that neurodivergent might not stay there. It might just walk straight out the door again. So you've lost them. You've lost the patient and possibly completely lost the patient, client, person.
And our ability to perhaps intervene early and provided them with that support. You mentioned, which really kind of the Kaufman's wheel. So that was another very helpful, pragmatic suggestion for our listeners. That you said that if I asked you, and often an opening statement would be something like, "How are you going?" Like something like that makes no sense.
Yeah. The worst question is, how are you feeling? It's like, whoa, suddenly a million things would come into a neurodivergent's head. And it's like, well, what do I say? And they go quiet. And so you're stuck there with a quiet client. You're like, don't know what to do with this now. Yeah. From a clinician's point of view, that's not where you want to go. You want to open someone up. So by asking more, I know we don't like asking those closed questions to our clients, but closed questions probably more useful with a neurodivergent than open-ended questions.
Okay. Yeah. So and again, that's really helpful because we spend a lot of time in Protect teaching people motivational interviewing strategies. And part of the motivational interviewing, kind of the first thing in the OARS skills is open questions. So being able to adapt your conversational techniques and strategies based on a person's kind of neurodiversity becomes quite important. So open questions may not be the panacea for everyone. So I guess that's another important thing that you're highlighting.
It may not be the first thing that comes to a person's mind when they're in a crisis to say, hello, I'm autistic. So you might not know that person's autistic. They might not come in with a background information. If it's an ED setting, for example, they might just walk in. So it's about sussing it out and seeing like, well, okay, this questioning isn't working. What could work instead? And being a bit more flexible about things.
That's really helpful. Yep, you good? Yeah. So when we were talking about different languages, it brought a smile to my face because I remembered my admin called me when this was just the time when I'd arrived in Australia. I think I was a week in, and she asked me, "How are you going?" Now, that's a very Aussie way of saying, how do you do, or how are you? And I kind of looked at her funny, and I said, well, I'm going where I was going a minute back, like nothing has changed. So when you were talking about different languages, it kind of brought that memory back of how kind of even both of us were speaking English, but kind of because she's Aussie and I'm not, how even the simple colloquialisms, I said that with a smile, I could work out what she was trying to say. And then we had a bit of a laugh about it. But it's so important to think that even when we are speaking the same language, we might be speaking different dialects of it, or because if there are people, if it's a spread and people are there in different points on a spectrum, there still might be differences that we are not aware of in the way we communicate and someone's preferred way or the preferred way in which they kind of, express distress.
One of the things I've noticed with clinicians is when we get distressed ourselves, like when we're fumbling within our clinical work, we tend to use humor quite a lot. And humor in neurodivergency is a difficult subject. Sometimes we will understand it, sometimes we won't. So using comedy, using jokes with us might alienate us further. So you have to be really confident in your practice. Like you have to walk in there with confidence and kind of know what you're doing and know how you're doing it to be able to be a confident clinician.
Yeah,
if that makes sense.
Yeah. So that's another tip as well, that actually, if you're going to use humor, you should know what you're doing. So that's helpful. I wanted to pick up the thing around body language. Because it's something that with our previous guest I was talking about. I asked this question of most of my guests. So I was speaking about this to Stan Steindl, who is a motivational interviewing guru. Through your mental health training years, we were actually taught techniques and strategies about your body language and how you lean forward, how you give your open arms and kind of 40-degree tilt and all of those things. Lately, I found myself saying that listen, if you are listening, you don't have to show that you are listening. So
Yes.
I've not been paying that much attention to all the body language stuff. And in fact, in Protect, I've been kind of, because it's about genuinely connecting with the people and that firm belief that if you are genuinely listening, people will get it that you are listening. And when you're not, people get it as well that you're not listening and you've got 100 things running through your head and you're juggling 10 different things. So again, with people living with autism, would you kind of say, so you mentioned that body language is quite important because that is a way in which you can communicate. But what would you say to this idea that irrespective of your posture or how you sit, or if you are listening, people get that you are listening? And if you're distracted, people will get, irrespective of the neurodiversity, that you are distracted.
I would just correct you once more there with autism, living with autism thing to autistic people. But autistic people, we learn body language very, very early, even before we're verbal. So I was hyperlexic. I read every body language book in the shelf before the age of 8. So I was very au fait with body language. It's one of the first things we do to be able to understand our world. As babies, body language is the main form of communication before anybody is verbal. Autistics tend to be later verbal, and so body language becomes very important to us. And so we learn to read body language as one of the first things, and as wary as a sign of danger. So if somebody walks into a room looking very serious, it's very impossible for us to take that person without the anxiety in our hearts. So if you come in from another client, and you've walked in, you've got 4 more clients to see after me, and you're looking very serious, you're trying to read my notes. I see anger, I see stress, and I feel that as well, because a lot of autistics feel what they see too. So I then take on your anger and your stress and become more angry and stressed. And so for maybe a level 3 autistic, someone who's less verbal, they might become angry and distressed in front of you. For a more verbal and level 1 autistic, or sometimes known as Asperger's, which is another contentious thing, so I probably shouldn't say that. But so we might go more introverted, might go quieter. It's like the fight or flight thing. So this fight or flight, the fawn or freeze. Some of us go fight or flight, some of us go fawn or freeze. So you walk into the room, and you're not actually thinking about, before you walk into the room, you're not actually thinking about the patient, you're thinking about everything else. So before a client walks into the room, they need to completely center themselves, focus on their body language of the client before they open that door. Because when they open that door, the first thing that I see will be your emotions, your stress, your frustration, or whatever it is you're feeling. And I will feel that too.
Because they might have, as yourself, have undergone training in reading body language as a way of deciphering the world around you, they might be even more sensitive or read meaning into things quite easily, unless as a doctor or a psychiatrist or a nurse, I am not aware as to, I'm not even thinking about that. But what you're pointing out is that we need to be aware of how we might be perceived by the person who's neurodiverse. So
we do cover it in training very early on, but then we forget about it. And we get so busy with our lives and our work that we forget that our body language is over 70% of our communication. And we go into a room we're busy, we have long shifts, long schedules, and we're not thinking about this stuff at all. And I recently taught aged care, and in my aged care I taught about Alzheimer's and those kind of conditions, dementia. And in the dementia training, I got them to do the sandwich. I don't know if you've heard of the sandwich making thing. So I got them to make a sandwich and give me instructions to make a sandwich. And the instructions they gave me were, take the peanut butter and put it on the bread. So I'd take the jar of peanut butter and put it straight on the bread. And they'd be like, well, that's wrong. It's like, well, that's what you told me to do. So the questions that you ask me, you need to really think about them, and the forms that you ask me to fill in. If you ask me to fill in this DAS, the DAS 21 or the K10 or whatever it is you're going to give me, you need to remind me that it's within the last week, or, you need to say, answer only these questions, or, some of the questions might not even make sense to me as a neurodivergent. Like, how do I feel with this? I don't know. Do I ask you what that means, or will I look stupid if I ask you what that means, or I'll just circle this one? So you might not get the proper insight into your client from a DAS 21 if you don't explain to them or work with them on the DAS, if that makes sense as well.
Yeah. No, that again, these are things that we normally do not kind of think about, that, because if you are a neurotypical and living amidst neurotypicals, you haven't got exposure to the world in this way. So it's almost like what you're asking us to do is get off our hill and get onto another hill, and you get to see a very different perspective of life. Because if we don't do that, then we would get things wrong in working with people who are neurodiverse. So
I think we've already got things a lot. There's so many neurodivergents that in psychiatric hospitals that are undiagnosed still, and prisons too, because it can come up as substance misuse disorders, things like that, where it's ADHD that people are trying to self-medicate. They don't know that they're ADHD, so they're trying to make sense of the world by self-medicating, and so we see them on the AOD wards. We see them on the borderline personality wards. We see them misdiagnosed and undiagnosed in all these sorts of areas, because rejection sensory dysphoria looks very similar to borderline personality disorder. And so to an untrained eye, that's what the diagnosis that people get. Bipolar disorder is another one people get. And there's a lot of research behind this, that these psychiatric diagnoses that people get before they come to the final autistic ADHD diagnosis, possibly in their 30s, 40s, where they've been through so much. The suicide rates are 3 times higher in autistics, and ADHD, they're higher than compared to other adults. The research is telling us this stuff. Mm. So, to identify someone as ADHD could be a lifesaver in itself. To identify somebody as autistic could be a lifesaver in itself.
So let me just summarize. There were so many golden nuggets in there about things that we need to be mindful of. So firstly, a degree of course correction in our Protect Suicide Prevention training, where of late I've actually been telling people, mind open, mouth shut, just listen up. If you're listening, the rest will follow. So I've almost actively discouraged people to think about body language and just be genuine in their desire to help, and it will come through. But I guess what I'm hearing is that if you're working with neurodiversity, then it's really important to be able to think about how they might be perceiving you and your current body language or your state of mind, and being able to think about that. So highlighting the grounds for mindful practice and putting yourself in the person's shoes and trying to look at the world from their shoes. And perhaps also not jumping to conclusions as well, because, their anger might be something that they have picked up from your demeanor, which might be something that you didn't intend to convey, but because of you're dealing with 5 patients, your beeps going off, your phone's going off, all these other pressure.
And the mask wearing has been a big thing in the neurodivergent world, because we can't see your face. We can only see eyes, and eyes can look very angry sometimes. And then we've only got tone of voice to go by. And especially if you're male, your tone of voice is very deep, and sometimes it can come across as aggressive. Mm-hmm. So you've just got to be really, really aware of this. Self-awareness is important in clinicians, I think.
Yeah. And I know that on a lot of our wards, certain nurses have been putting a picture of themselves on their apron just to kind of say, this is who I am. Some people have been drawing smiley faces on that mask, that I'm smiling at you beneath this. But yes, those masks, I know that in terms of infection control, we absolutely have to wear them, but they really make life very difficult, at least in mental health. I find that it's been a steep learning curve in connecting with people when I'm wearing my mask. They can't see me, they can only see my eyes. And you really have to make an effort to smile below your mask for it to be caught in the eyes that you are actually smiling. So almost kind of exaggerate that. So
it's a real effort to do that, though, isn't it?
It is.
It's just really great things.
Yeah, thank you for pointing that out, actually, because I think that has been quite a change in the the gift of COVID, hey, it never stops giving. So it's one of those things which we have had to kind of adapt our practice with. So,
sorry, back onto the body language things. One of the things in your protect is assess distress. Mm-hmm. And then one of the ways we normally assess distress is by someone's body language or what they, how they say things. But an autistic might say things very directly, and they might not appear distressed, but they might verbalize the distress. Mm-hmm. And that is very confusing to a neurotypical, because, I might say to you, I feel like killing myself, Banan, and you'll be like, okay, but you don't, and in your mind you're like, you don't sound like you want to kill yourself, you're not crying. Yes. So are you making this up? But an autistic person, that is how they present. They may well present as otherwise the average person, but they might come into you and they might say, I feel like killing myself. So it's a bit of a shocker for a neurotypical clinician to see that. And it might then ring alarm bells of, is this person borderline? Are they pretending? What is going on in here? It's incongruent, behavior.
Yeah, that is so helpful. So essentially, what we are asking our listeners to do is that when you're working with someone who's neurodivergent, if you kind of see something that is incongruent, be aware of what is going in your thought bubble. If you're beginning to think that, are they putting this on? Because from your neurotypical world, there isn't the congruent affect in terms of whether that be tears or a sad face, then actually trust the words as they are coming out. That's what I'm hearing from you, Shazzy. Okay. That is another really top tip to kind of keep in the back of your mind, that do not start second guessing what they are saying just because there is the lack of congruent affect.
Yeah, I think that goes back to your listening. Listen to the client. For sure. I know my son's a very anxious little boy. He's 8 years old, but his anxiety comes out very differently than the average neurotypical anxiety. So he won't shout and scream and cry, but he'll ask a lot of questions. He'll ask question after question after question. And that's the way that he's anxious. So in school, that's great. He's asking great questions. This is brilliant, but he's actually very anxious and he needs support at that point.
Right.
So, maybe your client's asking lots of questions. You're like, why are they questioning me?
Right.
Especially if they're a child.
I'm just thinking out aloud, and please pardon my ignorance. So if you're working with someone who's neurodiverse and they say something which seems affect incongruent, and you do get a thought in your head that I don't know what to make of what he just said. I'm thinking of killing myself, but he's not coming across as sad, or she's not coming across as sad or tearful. How would someone who's autistic respond if we ask a clarifying question at that point and say, actually, there's this part of me which is listening to you, saying this, expressing your distress. And then there's this other part which is wondering, I'm not seeing any emotional signs of distress. How might someone who has autism respond to something like that?
Well, obviously, autistic people are very individual, so I can't speak for the whole of autistic nation. But personally, if somebody asked me that question, I'd feel a lot of distrust against them, because they're distrusting me, and I would distrust back. So if you asked me, I can't remember quite what you said again.
Yeah, so because when we're working with someone where we are not sure, we would ask a lot of clarifying questions. And often so particularly when someone who is in suicidal distress, one of the ways that I find helpful to kind of talk about reasons for living and reasons for dying is I will often talk about me in parts. I will kind of say, there is this part of me which clearly is kind of listening to your distress and can see your distress and all the challenges that you have got in front of you. And then there's this other part which kind of sees this daily battle that you have got, but you are fighting it every day, and that you are here, you are kind of engaging in treatment, you're doing all the things. So there are these two parts to me. So I often use this technique of kind of two parts to me kind of questions. So that's what I was saying, that if I ask someone, there's this part of me which kind of is listening to your distress and what you just said about killing yourself. And then there's this other part, which is trying to connect the dots, but is not seeing the emotions attached with it. And I'm putting all my cards on the table and being open with you that this is in my thought bubble. And I just wanted to clarify this with you. I was wondering, with that kind of openness, how might someone with neurodiversity respond? So
personally, that might come across as accusatory. So you're like, you're not showing me stuff. Why aren't you showing me stuff? Like, what's wrong with you, kind of thing. That's how I would read into it. But that might be a negative way to read into it. But if I'm in a negative frame of mind anyway, the thought spiral goes down. So like you not trusting me, not trusting what I'm saying. Like if you say like, I see this, but then I see this. So like, it sounds like you're not trusting.
Yeah, I'm confused. Like, I don't know what to. Yeah.
Yeah. And so I've come into you as an expert expecting, some kind of answer. That's that's what we expect. We expect answers to questions. We're very direct in our communication, so we expect direct communication back. Right. So anything that's outside of that might be confusing and might then go into a negative thought spiral. Okay. That's how I would say it anyway, but it might be different for different autistics.
Yeah, absolutely. And there is no kind of, there's no panacea for every situation. And that's why we're kind of trying to explore this. So I guess mindfulness is one way in which, if someone is saying, as you said, direct communication, if someone is saying something with neurodiversity, take it at face value. Don't try to second guess it. But also I'm hearing is that, so something that I would frequently do with people who are neurotypical is I would put my cards on the table. I would kind of share my thinking and I would say, this is how I'm connecting the dots. Am I getting it right? So if it is done, it has to be done with extreme caution in people with neurodiversity because they might...
more about what you feel than what you see. So instead of like, I see this, but on one hand I see this, it might be I feel this about you rather than see it. Does that make a bit sense?
Yeah.
Well, I feel from you that there's some kind of sadness in you, but I'm not quite sure where that's coming from. I'm not seeing it, but I feel the sadness in you. Can you tell me a bit more about sadness? Is that something that's
quite helpful? That's quite helpful. So get them to elaborate a little bit more. Perhaps that may be a way in to what is it that they are actually feeling at this point in time.
And they may not know what they're feeling because of the alexithymia. We know what we're feeling, so we might need the Gottman chart to identify the feelings. And so all we know is that we're suicidal. We just want to die. So we walk into hospital, say, I'm suicidal, I want to die. And we're told to take a seat. So we take a seat and the lights are bright and things are hectic and chaotic as they are in hospitals. And we're like, I want to get out of here, fight or flight goes. And we start getting agitated. So we might pace around or we might get aggressive and I'll start asking the nurse on duty, when are we going to be seen? When are we going to be seen? When are we going to be seen? So often I worked in a mental health line a little while ago. And I'd call ahead for the hospitals for the autistics. We have a lot of autistic people on the mental health lines because that's the first direction they go in. We'd rather not turn up at hospitals. We'd rather not see doctors face to face. We're very homely people, especially in the COVID situation. So we call them mental health lines. And unfortunately, mental health lines, they only have a small amount of time to talk to us before they move us on. So when we're moved on, it's then like another transition, which then puts us into another chaotic circumstance. So we expect to call this mental health line that, I'm suicidal, help me. And what either happens, or in my experience on mental health lines, what either happens is we call an ambulance out, and make the situation a million times worse, or we send them into ED, where it makes a million times worse, or we pass them on to the local mental health team who then say, oh, it's not that serious, close the case. So there's a few directions it can go. With sending them to ED, which is the preferred route, we send them into ED. We give the ED a call. We say, we're sending this person to you. It's a category, whatever, A, B, C. We have different categories. And then I have the autistic person on the line and they've said, well, I've been into hospital 3 billion times. I don't like the lights. I don't like the way they treat me. And I don't have an alternative to that. As a person on the mental health line, I don't have an alternative to either an ambulance or sending somebody to an ED clinic. So I'm a big I'm a big advocator for specific neurodivergent services because the specific neurodivergent training is really important for us. And we have different mental and physical illnesses that happen to us. There's a lot of autoimmune stuff that happens within the neurodivergent community. Our mental health issues are similar, but not taken quite so seriously, especially in the child and adolescent mental health sector. Whereas you have CAMS. CAMS have their criteria. They have their cut-off criteria. And if you don't fit CAMS criteria or are autistic, you're then sent back to pediatrics. Pediatrics then well, it's mental health. And so you're passed between mental health and pediatrics as a child and adolescent, which is, you then suffer with medical trauma because no one's actually helping you. And we see, I get a lot of teenage clients come that then go to private psychiatrists, and the private psychiatrist refers to me because in Perth, I'm the person to see on neurodiversity. And I then look at this 14-year-old and go, well, they're neurodivergent, they're autistic, they're ADHD, and they haven't been diagnosed. They've been to see therapists throughout the years. I've got all this information. I put it all together and give them back to the psychiatrist and say, this is what is happening. And once they've got their diagnosis, then it's easier to work on their mental health on there. The suicidality actually comes down a lot once they've got their diagnosis and understand the reasoning behind it and understand that there's other people out there just like them. There's a whole community of autistics, ADHDs out there. It makes more sense for them. It's more, the belonging, act, belong, commit kind of thing. It's the belonging part of that that's really important, and being their authentic selves. It's really important.
Yeah. So I'm just trying to track all the things that you said, and there's so much in there. So I think well, I can feel your passion and your advocacy, and that's brilliant to see. So you talked about access and some of the challenges that are faced in terms of access when someone's coming through, whether that be a mental health call line or lifeline or suicide prevention lines. So some of the challenges that they face. Accessing ED or any team, how people are not able to perhaps access services in the same way as neurotypicals. Then we spoke a fair bit about engagement and connection and how perhaps engagement may be slightly different, being aware of our body language, being aware of our own state of mind and how that might be perceived. You kind of made some wonderful points around that. And then you took us into assessment, and you spoke a fair bit about how some of the assessment questions that are there in screening questions may not make any sense whatsoever to someone who is not neurotypical. And also being mindful about how we read someone's direct communication who is neurodiverse, and that there might be that disconnect between what they are saying and their affect, but to take it at face value and just ask for elaboration without judgment, and kind of perhaps not to make it too complicated as well, because of the direct nature of the communication that someone who is neurodiverse might engage in. So let's kind of think a little bit about treatment and intervention. So one of the questions, as I mentioned very early on in the podcast, that a lot of students ask is, when someone who is in a suicidal crisis, the crisis might have emanated from a relationship breakdown or, social factors, trouble in university or trouble at school, and often relationships are at the heart of some of those issues. One of the things that we would do with a neurotypical is engage them in distress tolerance strategies, or we would kind of engage them in cognitive restructuring, where we are kind of trying to get them to think about their thoughts and kind of help them see, look, you are minimizing all your achievements, you're maximizing all your failures, or you're catastrophizing, or, can you see that your thinking is black and white? I will see my friends when I get better. Well, actually, seeing your friends is part of getting better, how your thinking is black and white. How would these strategies kind of land with someone who is neurodiverse, quite direct and maybe quite concrete, as you kind of in your example put peanut butter on the toast, like the whole jar on there?
I think it's been proven. I think there's been a few articles recently about CBT not really working with neurodivergence. we are black and white thinkers. So telling me that my thinking is black and white, it's not new to me. I think black and white. That's autistic thinking. But the whole clinician asking, we're taught TPI, aren't we? We're taught, are you thinking of ending your life? Do you have a plan? Do you have intent? What are your protective factors? This is what we've done for 25 years. This is why I love what you're doing and the changes that are coming through, because it's well overdue. But that's how we're taught at the moment, TPI. And so, are you thinking of ending your life? Well, yes, I am. Do you have a plan? Now, what's a plan? Do I have a plan? No, I don't have a plan. But then I might go home later and go, I might just do this, and then, you've lost that person. Or, what protective factors do you have? Well, autistics don't have that many protective factors because we don't have a wider community. We don't have that socialization factors. We don't generally go out too much. Our friendships tend to be online rather than in person. So our protective factors are quite minimal unless we have families. And then we've got, children and husbands with protective factors, but a lot of us don't have that. So asking me about my protective factors might actually work in the opposite way. And I might actually start thinking, I don't have this stuff. I should have this stuff. Why don't I have this stuff? Oh my God, I really should die. I don't belong to be here. And then you go into that negative thought cycle again. So, just asking about protective factors could be just a negative thing. So this is why I like your protect model so much. Because that's not quite, you build the response, but you don't specifically ask,
Yeah. And I think thought, plan, intent, it kind of goes back to categorizing people into high, medium, and low. It's a very pointless exercise because, there may be low risk in your presence. I think what you said applies to neurotypicals as well as to neurodiverse. I may not have a plan now, but what is to say when the next round of bills come through and I'm going to be evicted from my house and I will not have a plan then. So I think, but again, I guess what I'm trying to do is tease out some of the different approaches we might have to take. So we in safety planning as part of treatment would spend a fair bit of time in looking at scenarios where I might be tempted to cross the ideation to action divide. So I am thinking about ending my life. I haven't got a plan or anything at this point in time. But what are the challenges that might come my way over the next week or the next month where I might be tempted, actually, I've had enough, right? And I am going to do something.
That might not be predictable for an autistic. So as an autistic, we have meltdowns. So we might have overwhelm over noise or sound or lights or something. And so it might just happen suddenly in the middle of a supermarket. We have a complete meltdown. And that is when the distress tolerance becomes too much and we're unable to tolerate things. We get overwhelmed. And that is when somebody might be at risk of suicide. Yeah. So it's not predictable in the way that it might be for a neurodivergent, neurotypical person.
Yeah, so in a way, kind of what we have been saying is actually it's not predictable for anyone because of the multitude of factors that can come. But we can engage in a degree of pattern mapping to think about, okay, over the last month that has gone, what are the different scenarios where you might have had a meltdown? And by meltdown, I don't mean just in response to stimuli, because of social circumstances and things like that. And let's think about scenarios like that, which might come up over the coming month, where you might have a similar meltdown. And if someone who is neurodivergent and kind of say the last few meltdowns have been in completely unpredictable scenarios, then there is a certain amount of predictability in the unpredictability, if that makes sense.
Yeah, so it does. I feel though that in the neurodivergent circles, it's more the feeling of being different, of being something less and different than others and not fitting in. So I see a lot of neurodivergents looking through Facebook, for example, I hate social media, by the way, but they look through social media, they see other people having great fun, great times. They think they should be doing that. And then a psychiatrist would come along and say, why aren't you socializing? You should be socializing. Socializing is really good for you. Why aren't you doing that? So they feel even worse. And like, well, I should be socializing. Why aren't I socializing? Why aren't I normal? Those kind of questions. And, that kind of thinking is again, that spiraling thinking. Like, why aren't I normal? And what's wrong with me? I phone a phone line. They say, well, why don't you go out and socialize? Why don't And so like 3 different people have told me to go and socialize. But, I'm a fish. I like swimming. I can't ride bicycles. I've never ridden a bicycle in my life. I'm a fish. So, it's about the clinicians being taught the differences of, don't tell me to ride a bicycle when I should be swimming. Tell me that swimming's normal. Tell me that, it's okay to be to have internet relationships. It's okay to socialize in the way that I feel comfortable with.
Yeah.
I don't have to go out and party to be happy. I'm quite happy on my computer, and a lot of neurodivergents are.
So in our safety planning, we talk about scenarios, so challenging scenarios that might come up. We talk about access to means. We talk about family, friends, and follow up. And then we talk about an emergency plan. So that makes up the SAAP. So scenarios, access, family, friends, follow-up, and emergency. And I heard 2 things. So one was in terms of scenario planning, we have to look for the unpredictable patterns that might be there. And in those unpredictable patterns, there may be something predictable, which someone who is neurodiverse is able to see and then perhaps plan for that. Actually, if it happens in the middle of a shopping center, what do we do? And then I also heard something about family, friends, and follow-up in terms of that safety planning component, in terms of how we approach that part of the safety planning conversation, where actually there may not be that many connections that they have got. And when we are talking about external coping strategies, that we do it with a degree of sensitivity, that who are the people you can connect with. And you kind of mentioned how the internet could be useful in connecting with people who are neurodiverse and they feel more comfortable in that space. So perhaps how we could weave that into their safety plans compared to kind of neurotypicals, where we might kind of say, think about a cafe where you can sit down and chat with someone. This may be a different approach in that safety planning component.
And access to neurodivergent, right? There's a neurodivergent phone line that not many people know about, not many clinicians know about, but it's not widely communicated, and it's not very well funded, and it could do with a lot more funding, but it does exist. And so instead of calling Beyond Blue, Lifeline, the normal ones, call the Amaze line, call the ones for neurodivergents who are manned by neurodivergents, who understand what is going through your head. So it might be in the middle of a meltdown that a neurodivergent might call the line, but the person on the other end of the line is like, I don't see the problem with not being able to, close your curtains or have a different color of curtains, or, this doesn't make any sense to me. Have you tried deep breathing? Have you tried the normal things that you go through? And then you've only got a 10-minute, maybe 8-minute window to answer that call. And then the call's then passed on. So as a neurodivergent, I talk a lot, or we talk a lot, and we want to just get things out and to have sounding boards. So to have that line that we could do that on is much more useful. But I think at the moment it's only open at certain hours.
Okay. So is there like like when we do safety planning with neurotypicals, we talk about internal coping strategies, and they are very simple things like having a shower, going for a run, doing some gardening, walking your pet, things that we would normally, we can do by ourselves. And while we are doing it, every time we can use an internal coping strategy, our amygdala, our brain is learning that suicidal urges come as waves, they come and they pass, and I can master it, right? Yes. That's one of the key messages of internal coping strategies. And I'm just wondering, is there a neurodivergent specific toolkit which perhaps clinicians and professionals can draw on so that they don't say things to a neurodivergent which sound absolute naff, like...
It's normally spend time with friends and family, and we might not have friends and family. But there is. There should be. There is in my book. One of those is like, what's your special interest? why don't you spend time on your special interests? And their special interest might be researching. We like to research stuff. So I know my son's special interest is penguins. So knowing everything about penguins, researching penguins calms him down a lot. Might seem silly or weird to a neurotypical, but it calms us down. So our special interests calm us down. I know a special interest of a colleague, a friend of mine, is the 1980s, and he likes to research everything about the 1980s. He's only 20, but he loves to research the 1980s. And so that is very calming for him. So, it might not be the typical running or mindfulness. It might be covert mindfulness. So I tend to tell when mindfulness does work with neurodivergence, and it works really well, but it's normally the covert mindfulness stuff that we use. So taking a shower and actually being present in that shower works really well. Asking someone to sit down and meditate wouldn't work quite as well. Having a meditation audio may or may not work, but having a meditation visual, a video to watch, would work better. We're quite visual people. So there's different approaches and again, it's different for each individual. So it's hard to, there's not a one size fits all for anybody, as you know. But
yeah, it has to be deciphered in a person-centered way. Can I pick up the access to means as well? Like, would you have any suggestions about how we approach that with someone who is neurodivergent compared? So with neurotypicals, we would say that we have a process that we go through in Protect where we go what, so what, and now what. So we would introduce a concept like, look, we would like to talk about what means you've got access to, and then we'll say, so what, which is the importance. We know that time and space, these suicidal urges pass. And so we'll talk a little bit about the importance of reducing access to means. And then we will kind of talk about the now what, which is the pragmatics. Like, I would now like to go through the different means that you have talked to me about, and how could we reduce them or remove you or get your family involved. So we'll go through a process of what, so what, and now what. Actually, we do that for scenario planning, access to means, family, friends, and follow-up in emergency. So that's what we try and teach, is to kind of work with the person as a true partner and develop this safety plan in which they have clear understanding of what is this bit of the safety plan about. And would you say that approach might work with someone who's neurodivergent, or do we need to make adaptations to that approach of what, so what, and now what in terms of access to means?
I think that would most certainly work. You would get very honest answers though, so be prepared for that as a clinician. People are very direct about what they plan to do, how they plan to do it. They might not give you like their stockpiles of medication or anything, but they might tell you that they have a stockpile of medication. So, you've got that, but are you going to use it? No. So, that's an honest answer. But why have you got a stockpile of medication? Well, I might need it in the future. What might you need it for? Well, I might want to end my life again. I feel okay at the moment, but what will you do with that stockpile of medication? Is there someone you can give it to? Like, is someone else you can give it to? It's very similar with neurotypicals. People lie about, stockpiles of medication or, means all the time. And nobody wants to tell a clinician that they have all this stuff just in case it gets taken away from them and they lose their options. But one of the things with neurodivergence is, and I always have in my office, I have a basket full of sensory toys and stimulation, because the interviews can go on quite a long time. And neurodivergent is, especially ADHDers, we like to walk around, we like to pace, we like to move around a lot, and it's impossible in an office that's the size of an egg. Most hospitals' offices are tiny. So I keep this basket of sensory items on my table. So, the bubble pop things and things to pull and things to touch and cushy balls. And that goes down really well and gets people to focus on what I'm saying to them more. So to get better communication from somebody who's neurodivergent, you need to get them to focus on you. To get them to focus on you, they might have to focus on something else. So they might be focusing on their phone. They might be focusing on the basket of toys that you have there. They might be focusing on the lights that are buzzing above their head. We have a lot of bright lights. And you might say, would you like me to switch those lights off for you? Like right at the beginning, if someone said that to me or any of my neurodivergent colleagues, friends, clients, that would be like the best thing ever. That would be like, you understand me, you get me. And straight away, that's opened up the empathy and the understanding for me. So, asking me if they want the lights off or on is probably the first thing to do for a neurodivergent. And automatically, I'm trusting you, and you've opened up communication already.
Oh my God, that is so helpful. And it goes back to the connection that you were saying right at the very beginning. How do we connect with someone who's neurodivergent? How do we show that you care? And this goes back to that empathy in action, cognitive empathy, emotional empathy, and empathic concern. So my genuine desire to help, and this very simple, but so powerful in getting across, I do care about your well-being, and I want to make you feel comfortable, and I want to be welcoming, and it's kind of speaking through your action. So that's beautiful. I guess the bit for access to means that you said, the honesty that you might get. So we need to be prepared for that honesty. But true in there a whole bunch of important stuff around sensory profiles of people, and how kind of when we are thinking about internal coping strategies, if we have worked with someone and worked on their sensory profile, there may be clues in there as well in making that safety plan as to kind of draw on that kind of sensory profile.
And I think this is why it's important to have a good team with you as well. Like working alone as a psychiatric professional, it's great, but I always work with an OT. I always work with an OT. I always have an OT as part of my team. OTs are essential to the neurodivergent experience, and so getting that sensory profiling done, getting the you need it for NDS funding anyway, if there's any NDS funding. So an OT does a lot more work than you give them credit for, really. Yeah. I love OTs. I'm a big fan of OTs. Yeah. The more I've learned about what they do is fantastic. And I actually, when I used to work at a hospital, when I first came here in 2008, I worked at one of the big hospitals here, I won't name it, but I actually learned more from the OTs than I did from the other nurses. The other nurses, Australian nurses, and it's probably going to sound really offensive, but they're not trained in psychiatry. They maybe do a couple of weeks placement in psychiatry, which I found shocking when I went into teaching. I did a lot of nurse training at the universities and at TAFE here. And you see that they only do a week's training, and it scares people out of psychiatry quite a lot. So it's such a shame the way psychiatry is taught from the basis. But the fact
I think that's the biggest difference between the UK and Australia is the nursing, because, you get 3 years of mental health nursing before you become a nurse over there, and what a difference that makes to. We do group work as part of our training, but here we're not even allowed to run the groups in this country, which I find very odd. Yeah. And then being part of the ACMHN, the Australian College of Mental Health Nurses, and the specific training we get there is a lot better. But when I see the training that we get on neurodiversity and autism, it's shocking. It's absolutely shocking. And I have talked to them about it, but the training standards need to go up within mental health nursing, but within mental health across the board. Yeah. Before we kind of try and wrap it up, I do want to ask about the emergency plan in a safety plan, right? So we again follow a very similar process of, what are we going to do? Like introduce the concept, the what, the so what, why is it important to have an emergency plan so that we don't have to think and create it in the middle of a crisis. And the final thing, the now what, the practical steps of doing it. And in an emergency plan, we often kind of tend to identify where is the nearest emergency department? Is that where I would want to go to? How would I get there? If need be, like, will I be calling an ambulance? Will I be calling a family or a friend who will take me there? So we with neurotypicals, when we are kind of creating an emergency plan, we kind of work out those pragmatic steps in advance. It's a bit like a scenario plan, really, that helping them understand what is an urgent situation, what is a crisis, what is an emergency, right? What are the differences between these three tiers? How do you differentiate out an emergency from a crisis? Because in an emergency, I've tried a number of things and I'm still feeling like taking my life. How do you differentiate that out? And when it reaches that, I need to be at a place where I'm safe, whether that be my parents' place or whether that be an emergency, so we try and think that through in advance. how should we adopt or adapt some of that conversation around an emergency plan when working with someone who's neurodivergent?
My neurodivergent clients, they've been around the blocks a few times and they've been to the ED. The ED is wholly inefficient for neurodivergence because of the noise, the lights, the busyness, and then them not be taken seriously. And then they're more likely to have a meltdown. When they have a meltdown, they're then, surrounded by security guards and, removed. And this is a neurodivergent in crises. And so they'd rather not go to ED. And they'd do anything they could not to go to ED. And so they'll go to counselling services or phone lines, and the phone lines are wholly inadequate as well. Some counselling services, they'll look for counselling services of neurodivergent counsellors or neurodiversity affirming counsellors, which do exist. I can't say it. Neurodiversity affirming psychologists, which exist. And I'd rather work in the community with them than go into ED. I'm trying to get my clients into ED. It's impossible. It's next to impossible.
When it's kind of, 9 p.m. at night and there aren't a lot of these services available, even in that situation, you would feel going to an emergency department. Of course, we can't predict about every scenario. I understand that. It would be preferable to kind of think through in advance, what are my other options than ED?
At the moment, emergency departments aren't neurodiverse friendly. They're not friendly. We could make them friendlier. It's not that hard to do. And then advertise them as neurodivergent friendly, and then somebody would be more likely willing to take up their service. But at the moment, they're not friendly. And having had first-hand experience of taking my son to ED when he was suicidal, it wasn't a good experience. It was a very negative experience, and not one I'd wish to repeat anytime soon. I'm not sure if that's WA. I know that's not just WA because I'm in WA. But having worked on the phone lines for New South Wales as well, I know it's probably a state over, countrywide. So safety planning is the priority, and putting safety planning in where people can call support workers. People may not have family members with autism and ADHD runs in families. And so many people are disengaged from their families, either because they are seen as an outcast social pariah, or their family has had mental health issues or drug and alcohol issues because of their undiagnosed neurodiversity. So they've lost, connections with those people. And so they're pretty much by themselves. So safety planning, as far as family goes, not great, but friendships, neurodivergents do have a lot of close friendships, then almost family networks. So, neurodiversity transects the LGBT community. And so the community is quite wide and broad in that way. And so there's always somebody that they could call that they might not think of calling as a as a friend. When you say family, like what family can you call on? They might not think of them as family because of their friends. So the language we use is quite important. The connection that we use is quite important.
What kind of stands out for me is kind of thinking of this in advance, because in the middle of a meltdown, it may be very difficult to think straight. So what you were saying is that safety planning is so important.
So I tend to say, like, we do a safety plan and stick it on the fridge where you can see it all the times. But even then, when you're in the middle of a meltdown, you don't look at your fridge. So that there are a couple of apps out there that are useful for neurodivergent safety planning. The most people tend to do is, I get a lot of emails, luckily not in the middle of the night, but I get a lot of emails. This just happened to me. I'm in crisis. Can you see me now? And, a lot of the times I'm like, yes, I can. I'm happy to do that. But there isn't anywhere else to go in that moment, apart from ED. And in ED, you have to wait for 6 to 8 hours at best in WA. I don't know what it's like over there, but 6 to 8 hour wait in ED is traumatizing in itself for anybody, let alone a neurodivergent. So that's just not viable. Again, seeing a psychiatrist, everyone's waitlist here closed, so it's impossible to see a psychiatrist with a specialism in autism here. It's absolutely possible. We're having to send clients over east to just see a psychiatrist. So there's literally nothing for neurodivergence over here apart from counselling. There's even counselling have waitlists. Psychology's waitlists are closed over here. I think there was a 6 to 12 month wait for psychology here. So our options are very limited. To have a walk-in centre, to have the GPs get a lot of autistics in, and having GP training would be an ideal thing. There is an RAC GP training on autism, and there is documents out there that help underline the autistic nature of things. There's actually a GP network, a doctor network of neurodivergent GPs and neurodivergent doctors that help underline the facts and what is needed from the neurodivergent community, which is fantastic. But, having an open door policy on some kind of services would be fantastic. That isn't ED, that is maybe a 24-hour GP service, which we do have. We have GPs that you can call out here. But again, they might not be knowledgeable in neurodivergent factors, and they might only be able to, do the minimal.
And I guess that's where the training comes in. So again, before I attempt the impossible to summarize, an hour has passed. I can't believe time just flies. All the knowledge that you have thrown our way. If people wanted to get in touch with you regarding neurodivergent training or, the talks that you do, how might they do that? Would that be through LinkedIn?
I'm on LinkedIn. Yeah, I talk about it all the time on LinkedIn, as you know, but I also have a website, positivelyliving.com.au, and it outlines all my services, my neurodivergency services, and training is on there as well.
So positively.living.com.au.
That's right.
Brilliant. So we'll put that on the show notes as well, so people can kind of locate you. And as our listeners would have heard, you are absolutely passionate about neurodivergence, and some of the kind of simple tips and tricks that you talk about can make or break a relationship when it comes to connecting with a person in crisis. So now let me try and attempt to kind of recollect all the things that you have spoken about. So we started off talking about language and the importance of language, and how we frame someone, whether we say, like I'm quite used to saying living with schizophrenia or living with depression, but you would much prefer that for us to be saying autistic people. So there is a difference there, and for us to be really mindful about that. You talked a lot about access in terms of accessing services and how there are limited options available. And when referring someone on to an ED, that we really need to be mindful about the impact a busy, noisy emergency department may actually have on the person, and how it might perpetuate the crisis or even make it worse rather than help. So I think that's something for us to keep in mind in terms of access. You kind of highlighted a number of things around connecting with a person as part of that assessment, being mindful of our own body language, being mindful about what kind of emotional space we are in because of our business and how that might be read. You talked about masks and how often it is quite difficult to, just from the eyes, to be able to read how a person is feeling. You talked about how neurodivergent people are often very direct. So in our assessment, not to kind of try and second guess, just ask them to elaborate further. And that may be a helpful way to kind of ask for clarification. You also highlighted the role of closed questions in working with people with neurodivergence. And that was quite a helpful thing to think about. I'm sure I'm forgetting a number of things that you said in relation to assessment. Yes, we talked about body language quite a bit, which I think I mentioned. And then we jumped into a bit of discussion around interventions and things that we would normally do, like cognitive restructuring, which is CBT based, and how different approaches one might take to that kind of CBT based approach, where we are kind of going through cognitive errors, black and white thinking, and kind of you mentioned, well, you telling me I'm black and white doesn't really help me because I've known that all my life. So, but then we got into the nitty gritty of safety planning. So we looked at the SAFE protocol, and you mentioned a different approach to scenarios in terms of thinking about unpredictable scenarios that might have happened before, and how that could be built into a bit of scenario planning, like a meltdown in a shopping center because of all that stimuli. Because some of the scenarios may be quite different between neurotypicals and neurodiverse, and to be mindful of those differences in terms of when someone might feel that their world is imploding. We talked about access to means, and you mentioned being kind of to be prepared for some direct answers, but working with the person in terms of reducing those access to means, really working on that collaboration and that partnership, rather than just telling people, otherwise people would just tell us what we want to hear. We talked about family and friends, and you kind of highlighted how actually a lot of the family connections may be disrupted because of the autism and autism running in families, and the role of friends who are neurodiverse, and how internet may actually play a part. And people might feel more comfortable connecting over the internet than kind of face to face. And then we kind of talked about how we could pin down the specifics of an emergency plan, again, in terms of the people we can get in touch with who are perhaps neurodiverse, and having that in advance. And all through that, you strongly kept advocating for more neurodivergent training and making our environments, our healthcare facilities, more neurodivergent friendly, and that it is actually not that hard. And perhaps it needs a bit of leadership, a bit of will within services to see the world in a different way. What did I miss, Shazzy? And you can have kind of final comments for this episode.
You pretty much covered it. I think that's remarkable. But a couple of things I didn't maybe mention was just to elaborate on the direct speaking part of things. A neurodivergent in crisis might actually come across as quite rude, and we might come across as quite aggressive. We're not actually physically aggressive, but we might seem quite agitated and rude when we're trying to get all our thoughts out of our brain through our mouths. So don't take it personally as a clinician. If somebody is rude or comes across as rude to you, it's kind of like tone policing. Don't tone police somebody in that way. And then the holistic point of view. When I look at clients, I look at them holistically, as I'm sure you do. And the inflammatory processes within neurodivergence is huge. And so we're very sensitive people. So just a change in medication might set off suicidality, low iron, low vitamin D, low B12, stuff like that. Just having a general blood test will just maybe give you more insight than anything. And just having those simple changes might change our thinking patterns quite rapidly.
Yeah. So there you heard it. Healthy body, healthy mind. So do not neglect the physical side. And kind of final words, do not take it personally, because they are in distress. They may be quite direct. It might come across as very rude, but that's not the intention. That's how they're expressing their distress. Thank you, Shazzy, for taking the time. Really appreciate it. A wealth of knowledge, and wish you good luck in all your endeavors and the advocacy work that you have been doing. You have been absolutely awesome. Thank you so much.
Thanks for having me. Have a great day.
You too.